may also be streaming meeting live and archiving it for additional viewing opportunities. For everyone's reference, today's agenda can be found under the first tab in the materials. Sue Birch, Chair of the Healthcare Cost Transparency Board, will now call the meeting to order.
I'm calling this meeting to order. Hello, everybody. I'm Sue Birch. Welcome, board members. And I want to just call out that we have a special WISMA representative in the room with us today, our first in-person public person. So Deb, thanks for being here. It's 2:05. This is the December 7th meeting of the Healthcare Cost Transparency Board, and we are going to begin. It is always great to gather. We really encourage board members when we are not in an atmospheric river to travel in and come join us in Olympia when you can. And we welcome the public as well for these meetings in the future. However, we get the need to keep having meetings hybrid. So anyways, welcome everybody. There's a few things I want to just comment on. And I'm sure many of you have seen a number of things that I'm going to be mentioning. Monday, the New York Times ran an article on the healthcare prices in the US and the need for action to help control healthcare costs. The article was really great, highlighting the fact that the US spends more per person than any other country, and yet we have the lowest life expectancy of any high income country. We will get that article out to you, and I'm going to just pause and welcome another in-person board member. Ingrid Ulrey is joining us. Actually, she's the only other in-person. I called up Jeb in the public audience, but
Great.
Thank you, Ingrid, for joining us in person.
Thank you. Sorry to be late.
Anyways, that New York Times article really underscores the work that we're doing together as a board. Especially today, as we discuss the findings from the first preliminary benchmark in our analytics strategy initiative to take deeper dive into healthcare costs. In February, we are going to begin to utilize all of the information that we've gathered to think about potential options to control healthcare costs within our state. We are going to send the board members a copy of that New York Times article. I also just want to point out that this week there have been a deluge of big reports. Just this morning, the White House released, and I don't have it in print, but at 10 a.m., Vishal tells me that the White House released a new report on 5 new measures to assist in reining in healthcare costs. You will not be surprised that there is a big section about drugs, and there's another section about ensuring competition, and we'll get more out of that document as we get the full document, and we'll make sure to talk about that in the future. But we were just really pleased to see that roll out this morning. Another report that many of you will see and we will be discussing in coming months is the Attorney General's preliminary report on healthcare affordability. I'm not going to go into this one, but I do think, again, these are really significant reports. Another one, and I don't believe, Jane is with us, but we also, Jane, are holding up the other report out from the Washington Office of Insurance Commissioner's preliminary report on healthcare affordability. So we have just all sorts of good information to keep digesting and processing, and I would be remiss, since Ingrid just came in. There was also good information recently about the Cascade Care Work Group and the impact of public option. So again, lots of material coming out in this area. We will continue to process it and distribute. So what I'd like to do now is have you open up your packets. We're going to go to tab 1, and let's do an overview of the agenda. I'll provide this brief overview of the agenda today, and then we'll begin with a roll call. But you know me, I always like this little human side of engagement. So I am going to ask you, as I call on you, to think about what is your favorite holiday tradition? So just, start preparing. After roll call, we're going to introduce the October meeting summary. And then to approve, and then we'll hear public comments. After the public comments, Joe Dealman is going to present on his proposed analytics strategy for the Analytics Support Initiative for board approval. Then our very own Vishal Chowdhury is going to present the healthcare spending preliminary results for the benchmark, that long-awaited report that we are excited to see. After that, we'll get an update from Dr. Judy Zerzental on the primary care committee's work. Then we'll discuss the possibility of creating a nomination committee. And to close, we'll review the board's calendar for 2024. I really encourage you throughout the meeting to ask questions, give your feedback, and just we want to keep having a very robust discussion and keep getting your recommendations for the board process. So I want to thank everybody in advance for their time and their efforts. And please remember, what is your favorite holiday tradition? And I will just start that my favorite holiday tradition is sitting near that Christmas tree on Christmas Eve. And I just love that with a hot beverage and seeing a beautiful lit Christmas tree. So that's my thing that I just love every year. I will turn this over now and we will do the roll call. Jane Beyer, what's your favorite holiday tradition?
So my favorite holiday tradition is whether with my children present in person or whether we do it over FaceTime, saying the blessings when we light the Hanukkah candles.
Beautiful. Eileen Cody, you're with us with that lion. What's your favorite tradition?
Oyster stew on Christmas Eve. We did that when I was a kid. That was always, and so then when I met my husband, he insisted if we were going to do that for our married life, that it had to be a better soup. So it's now a little more gourmet with other seafood included, but oyster stew.
Oh my God, I knew that I liked you as my friend. I love oyster stew. Wonderful. Lois Cook, are you with us today? Lois, are you there? I don't see her on the board. We'll come back. Staff, will you alert me if Lois?
She did mention she was having some technical difficulties
Come
where
in.
she was, so she might have not be able to.
So we will circle back. Bianca Frogner.
Hi, here. Gosh, I was trying to figure out what's my favorite. I think I'm going to throw out three things, so I'll be quick. One is I love putting up Christmas lights around our house. It's it's a labor of love. I enjoy doing it. And then on Christmas Day or Eve, I typically get together with my parents. My husband has now joined us, so we're a family unit of 4, and we like to go out for a buffet. My dad loves a buffet for Christmas, so I feel like we're hunting for a buffet all the time, and then hunting around the town looking for Christmas lights. And my dad always says he wants to look for Christmas, and to him that really means Christmas lights. So spending time with family, really, and being festive about it.
Wonderful. Jody Joyce, are you with us? Let's see, Jody. Okay, Mark Siegel. Let's see, Margaret Stanley.
Yeah, my favorite Christmas tradition is a big family dinner at Ray's Boathouse. And this is a tradition that's been going on for about 35 years and has about 50 people.
Wow.
Yeah,
Sounds like quite the celebration.
yeah.
Wonderful. Ingrid.
Well, I love the question, Sue. Thank you. This is going to sound odd, but my favorite is a road trip that we always do on the 26th of December with usually just me and my sons. And we drive all the way across Highway 90 into Montana and then dip up into Northwest Montana. It's a hell of a drive, and we listen to musicals and sing. It's super fun.
What, is it just a loop or do you just
No,
go
we
out?
drive to, sorry, I forgot to
Your
explain the
mother.
destination to see my mother.
Kidnap your children through Montana. Go see your mother.
Yes, thank you. Thank you for adding to that.
Wonderful. Kim Wallace, can you top that road trip?
Oh, I don't think so. But I will just share that favorite tradition is on New Year's Eve. I purposely make myself quite very still and quiet and alone. about 11 o'clock. And then I light a candle, turn off all the lights, light a candle, and be very quiet and contemplative about the upcoming year. And I stopped doing that around 12:30 or 1 o'clock.
Nice. I think that just dropped my blood pressure, just that visual. That's beautiful. Carol Wilms. I don't see Carol. And Edwin.
Hi, I'm here. Yeah, so I go, my family, my extended family, we tend to go out of town in between locally somewhere kind of remote Washington in the week between Christmas and New Year's. And I guess within that gives us lots of opportunity to play board games. So I especially relish the opportunity to be, in particular, my father-in-law at games like Scrabble and chess. So I think that would be a new and emerging favorite tradition.
Wonderful, wonderful. Well, I sure hope that we all keep these traditions going and take time. So fabulous. Did Lois, Jody, Mark, or Carol happen to jump on? Can staff tell me if we had any late entrants? No, I don't think so. Okay, we'll note that for the minutes. All right. Thank you all for those inputs. By the way, I hope you got the pumpkin chili recipe after Thanksgiving. And now I feel like we need to send out the oyster stew recipe from Eileen. All right, let's get going. I would like to have you turn to tab 2, and we are going to look at that summary, which is being shared on screen. Can we enlarge that a little bit or no? As a note, the recording of the last meeting is posted on our webpage for reference or review. And we're going to use the consensus process for a vote on the approval of the meeting summary. Is there any discussion of the October meeting summary or proposed changes? Margaret?
Yes, I was just curious about why you were including timestamp in there. It seemed odd. There were several places where it said timestamp.
We're trying a new format, but if it's odd to you, we'll certainly strike them and remove those. Okay, just as a note, this is a new format. We're trying to shorten it. I know sometimes it can be a little long. We're trying to find a formula to sort of be better referencing for cross-board members and also to sort of shorten the ability so that it wasn't such a long document to read, but sort of encapsulated the talking points. And so we'd be happy to remove those indicators.
If I'm correct, it looks like the timestamps are mostly used to identify when we're having kind of more free conversation with Q&A. Is that typically how it's being used?
Yes, it'll take you to the YouTube mark in the video so that people can easily get to that section if they wanted to review it.
Margaret, do you have thoughts one way or the other?
No, I think in general, I think minutes should be meaningful, but not overly long. So just personally, I would be unlikely to go to a YouTube video for the discussion, but maybe it's useful to other people.
Anybody else on the board have thoughts or preference?
I'll mention that I did also notice the timestamps, and I could see the value of having timestamps for anyone who's trying to figure out if they want to jump in and kind of catch up on a particular topic to go there. My only worry is whether or not we're capturing what some of the questions were and the responses were in that discussion. I know in prior minutes we had still relatively brief summaries of what the gist of those conversations were about. So I would encourage that perhaps we still have some kind of summary statement around kind of the conversational pieces of it, or like what kinds of questions were asked, in addition to the timestamp, so that piece isn't lost.
You're talking about in the sectional presentations?
Yeah, I mean,
The primary care committee, I'm just double checking and confirming
Well, let's see, like, I mean, when I look through the various paragraphs, the summary statements are mostly about what happened in the presentations. And then most of these paragraphs are ending with things like questions from the committee began at timestamp, et cetera. And that seems to happen for most of these paragraphs without any sign of what kinds of questions were asked and kind of what some of those responses were, leaving up to somebody to have to go watch it to figure out what was the conversation. And if I remember correctly, in prior minutes, while certainly those conversations were not elaborated on in great detail in the agenda, at least it gave some flavor for what kinds of questions were asked and what some of those responses were. And maybe that's the one element that I'll say in the minutes that I noted as feeling somewhat missing is that part of the summary.
Thank you for that input, Bianca. Morgan, I think is your hand up a second time, or did you have a response?
No, I think that she said exactly what I was thinking, and my hand was not up again. I just forgot to take it down.
Okay, all right. Well, I would suggest that we leave the timestamp in for the time being, and let's see if the next iteration we're more comfortable with it. If we're not, I do think it provides the public kind of a go-to that time frame if they're looking for something. So I would suggest, in the spirit of our hybrid and technological advances, that we leave it in and then think about how we can encapsulate a little bit more, not too much, because I get it that staff is wanting to have brevity to the reports, but let's leave it in, and then we'll revisit it if there are concerns, or if we feel like it's too confusing or problematic, we'll delete it in the future. Okay, but for the time being, we're going to try it. All right, is there a motion to approve the minutes?
So moved.
So moved.
Thank you, Margaret. Is there a second?
Yes, second.
I think that was Kim. Great. All in favor, say aye.
Aye.
Any
Aye.
opposed?
Aye.
Any opposed? All right, the motion is approved and we will move forward. We moved public comments forward, and I want to welcome at this time public comments. I don't believe we had any written public comments.
No, there are public comments under the tab in the materials.
I'm sorry.
That's all right.
Okay, so those comments are under that third tab, and we want to allow individuals to sign up to provide public comments before the meeting, and we'll start with those that have signed up to provide comments. If you've not signed up and would like to provide public comments, please raise your hand. And then Mandy's going to call on you after we hear from individuals who have signed up. When you're called upon, please state your name and affiliation, if any, before speaking. And again, accept this invitation to become a panelist in order to provide public comments. The staff will trigger your technological signal. Let's see, please don't raise your hand more than once. This helps to ensure that everyone has a chance to speak. And you're also welcome to provide comments in writing via email at any time. So Mandy, would you please start with the names of individuals, if any, who have signed up to provide comments?
The first person is here in the room, Jeb Shepherd.
Right here's okay.
Yeah, sounds great.
Perfect. Chair Birch, members of the board, healthcare authority staff, on behalf of the Washington State Medical Association, representing nearly 13,000 physician and physician assistants practicing across the state of Washington. My name is Jeb Shepherd, and appreciate the opportunity to provide public comment today. Would like to call your attention to a letter that we submitted that's included in your meeting packet. Thank you, Mandy, for getting that in there. That serves as an update from the independent physician community. In that letter, we provide two very recent, very local pieces from the Seattle Times and the Kitsap Sun around the challenges that independent practices are facing in today's challenging environment. The Seattle Times piece tells the story of how Seattle OBGYN has had to close its doors after 73 years of providing care. The loss of that clinic will affect 16,000 patients, which includes over 300 pregnant patients who now have to scramble to find a new doctor to deliver their babies. The practice's closure is the result of the same issues impacting physician practices across the state and the country that make it increasingly hard to find affordable, timely, and necessary medical care. Challenges the challenges include low reimbursement rates that do not keep up with the cost of providing care. Medicaid reimbursement rates for professional specialty services in Washington are some of the lowest in the country. Over the last 20 years, Medicare reimbursement rates adjusted for inflation have fallen 26%, while the cost to run a physician practice has increased by almost 50%. This issue is expected to be worsened if the 4% cut being considered by Congress goes into effect on January 1. Physician practices that see Medicaid and Medicare patients generally do so at a loss, and many independent practices do not have market leverage and must accept take it or leave it contracts from insurance carriers. We've seen drastically increased workforce costs, increased administrative burden that places much of the cost of delivering care on physician practices, a disadvantaged state B&O tax that was increased by the legislature right before the pandemic in 2019, and the list goes on. As noted in the letter, we've watched this dynamic that was accelerated by the pandemic unfold over the last decade across our state, and with more and more independent practices put in a position of selling or merging with large health systems so that access to care is maintained in the community, the only other option is to close. The OIC and AG recently released preliminary affordability reports that Chair Birch referenced earlier. We understand those will be topics of discussion many months to come, and we anxiously await the next round of reporting. We're still reviewing those current reports, but what stood out to us is while there's a lot of discussion around the price of services and consolidation, there are no recommendations that would help address the issues that are outlined in those articles, and we're focused on my testimony today. We believe that are actually driving those two trends. So we believe that one way to lower costs for consumers is to make healthcare easier and more affordable for physicians to deliver. And we hope that you'll consider these challenges as you carry your work forward. Thank you.
Great, thank you. Who's next, Mandy?
Next, I have Katarina LaMarche.
Hi, thank you, Katarina LaMarche, Policy Director at the Washington State Hospital Association. I just actually have a few questions for the board related to plans for the upcoming year. The first is whether the board plans to reconsider or reaffirm the benchmark for 2024. I know previously the board had decided not to revise the benchmark for 2022 or 2023. Despite inflation, which included really large salary increases for hospital staff. A couple stats from the Bureau of Labor Statistics between 2013 and 2022 showed that Washington State was sixth highest for RN annual average wage inflation, which was at like 33%. And for LPN, it was at 45%. I recall the justification for not making those revisions was based on provider rate inflation, lagging salary increases, since hospital payments can't be increased until new health plan contracts are signed. And we're at that point now in time, and so we're hoping the board will reconsider this issue. And the second question is specific to the agenda and work plan for next year. We're hoping the board is able to, spend some time early in 2024, if possible, discussing how the provider-specific benchmark will work. We know it won't be calculated for a while, but now might be a good time for providers and for the board to sort of understand the process. This, was addressed in the motion that the data committee passed, which outlined the questions they'd consider on this topic from which they would be able to provide recommendations to the board. And I don't think it's entirely clear to us when the committees will be addressing those questions, because it doesn't look like provider and data committee meetings have been affirmatively set. So my question is whether that will be addressed during the discussion of the work plan later in this meeting. And just one last thing on the meetings for next year. We saw that it only goes holds for meetings depending on the board's needs. And just, if we take a step back and consider the purpose of the committees, which is to provide expert advice to the board from individuals who have really invaluable insight and context and information about how care is being delivered in Washington State. It's kind of hard to imagine when their perspective and feedback wouldn't be needed. So we'd strongly encourage and appreciate a set schedule and for agendas to be set in advance, to encourage committee member participation and also to help the board. So thank you again for the opportunity to provide comment. And if you have any questions, I'm happy to answer.
Katarina, thank you for your comments. And board members, I remind you that later in the agenda, we'll be looking at calendars, and this work and these questions over time are things we're going to be discussing. So thank you. And who's next to comment?
I saw Sharon Elaranta raised her hand. We admitted her, but then she lowered her hand. I hope that she still wants to provide the comments.
My hand should still be up, but again, maybe I had twitchy fingers. Thank you for giving me just a minute. My name is Sharon Elaranta. I am Medical Director for Performance Measurement and Practice Transformation at the Washington Health Alliance. My Executive Director may be on this call as well. I don't know. But this is just a quick addition to the list of cost-related reports that have been released today. The Washington Health Alliance today released a report on the health waste calculator. So you may have been familiar with our reports on this. They were called First Do No Harm. Several years ago, we did a few in a row, and we have updated that information today. And what is different about it is that we have taken that our all payer claims database and then run it through the health waste calculator, but also applied the area deprivation index. So we have a look at waste across levels of socioeconomic challenge in our state of Washington. And the results are really interesting. And it's definitely cost adjacent, because you can see where we're wasting money and how much money and what we can do with that saved money to reduce costs for others. And that would be at lawcommunitycheckup.org.
Thank you, Sharon. I had not seen the email yet, but Drew had told me it was forthcoming. So we will distribute that out to the full board when we see it. Thank you. And who's next?
I don't show any other hands raised.
So any other members of the public that are listening in, if you could signal by raising your hand or speaking up if you can't find that hand raising feature. I don't see any, so I think we at this point are going to close public comment. All right, thank you for that input, and the board and staff will certainly be rolling these comments in and questions and whatnot as we move through our work in the coming months. So I'd like to now welcome Joseph Dielman. He is from the Institute of Health Metrics and Evaluation. He's going to lead us through the proposed analytic strategy and voting to provide the board with additional data for the development of the healthcare cost mitigation strategies. Joe has been before us before. Welcome, Joe, and I will turn it over to you.
Great. Thanks, Chair Sue. Thanks. It is a pleasure to be able to speak to the group again. Thanks so much. I'm here today with a pretty specific task. If you recall, our project spans really 2 years. The first 6 months is coming to an end, and the purpose of the first 6 months was really to decide what we're going to do a little bit of landscaping, to talk to experts, to get your feedback, and then put forth a path forward. And so today our goal really is to propose that path, get any final feedback, and then really hear approval from the board or get concrete changes that could lead to very specific amendments. And so that will kind of take place over 4 different pieces. The first is I'll present our kind of 3 proposed analyses. So these are kind of analytic activities that our team would do over the course of 2024. There's a 4th idea that we've been kicking around and really wanted to talk to the board about. It was something that was recommended by a collaborator and something that we thought warranted feedback from you guys. Finally, the 3rd piece is just to talk about what we think we'll do with those analyses. So we'll take the analyses and turn them into specific products. And so we have a list of what those products are. And then finally, the last piece is examples of what could be done with those products. And so I'll walk through those 4 pieces now. And just to be clear, I'm very comfortable taking questions as we go. There'll be time for discussion at the end. But if there is anything to clarify or anything that's unclear, please jump in. So like I mentioned, there's 3 specific analyses that we're proposing. The way that we came up with these 3 analyses is this kind of 4-step process that I wanted to outline before going on to talk about the 3 analyses. So the first is we just thought about my team's strengths and what we can bring, different past projects that we've worked on, the data that we've pulled together, estimates that we've produced, and thinking about how those could potentially contribute to the cost board. The second is feedback from you guys and from the advisory committees. We've met with the advisory committees on a few occasions, as well as talked to the board on 2 occasions as well. And that feedback has really been invaluable. So the hope is that what is being presented today is not so much a surprise, because it really comes from discussions that we've had with the cost board. As I mentioned before, we've engaged with local experts and experts across the country to get their feedback. That includes individuals doing similar work in other states, as well as people representing different organizations here in the state of Washington to get their feedback. And finally, we've worked with the HCA to make sure that what we're proposing isn't duplicative. We don't want something that we're doing to line up closely with what any of the other kind of analytical tasks that have been set out by the board are doing as well. So what we believe what we're presenting is actually quite distinct. I can go on to the next slide. So here's the 3 analyses. They can be summarized with thinking about estimating, then followed up by adjusting, and then finally talking about decomposing. And so what do I mean by those things? First and foremost is an activity to just understand spending at a fairly granular level within the state. And so that means specifically looking at spending and spending per capita across time and across counties by payer and by cause. And the analysis really would focus on 2010 through 2022. And the second part of that estimate is also measuring utilization. So the first part is measuring spending. The second part is measuring utilization. Again, making comparisons within the state and comparing Washington State to some of the neighbors or other peers that we're interested in looking at. After we've produced those estimates, the second piece is to adjust those estimates. And specifically what I mean is to adjust them for common characteristics or major risks that exist within that county. And so we'll do age and risk standardization. This is a little bit different than risk standardization that would come from maybe specifically claims-based risk standardization, but it instead is adjusting for the environment, for the characteristics of each of the counties. And so examples of the things that we could control for are insurer rates, income, education rates, obesity rates, tobacco use, those sort of things. So the objective is to, again, try to compare apples to apples, but not depend on claims data to do so. Because I think we've had conversations, and there's been a lot of conversations nationally about how using claims for risk adjustment can lead to biases. The last piece, the third piece, is to decompose the differences. And all I mean by that is to, across the county and across time, to assess how things are different or how they've changed, and ask the question, can we explain those differences, or can we explain what's changing over time? And the categories that we look at often are changes in the demographics, so the age and size of the population. The next piece is the disease prevalence, so the kind of the epidemiological perspective. And then the last two pieces are kind of more health services. I'll look at changes in utilization or differences in utilization across county, and the price and intensity of the care. So how has that changed, and how does that contribute to the additional spending? So the idea is that those three analytical products, the three analytical analyses, can be bundled up into a few products. And so I'm just going to list the products here. The first is just kind of a comparison of Washington State to, like I said, peer states or local, Oregon, California, Idaho, and kind of a baseline context setting analysis. Second piece is looking at cross-county variation. And so we have kind of 4 different ways that we're thinking about doing cross-county variation analyses. The first is just looking at spending. We want to point out that we would look at counties, and I kind of keep saying counties, but really we could look at any geographic aggregation of counties. And so it's kind of been brought to our attention that the accountable communities of health and the geographic rating areas might also be valuable geographic areas to make estimates at. And so we can do that because they're aggregates of counties. So the first piece is really looking at variation in spending across the counties. The second is looking at variation in utilization and pointing out where there are differences and using maps and other figures to do so. The fourth part here, letter D, the third on this page, is looking at a list of health conditions that really have the most variation. Why is it that per prevalent case, treatment of one disease is more expensive or has more utilization in some counties over others? And so that will be provided in a list format. And then finally, the last piece is kind of going back to that decomposition to try to understand. So we'll produce figures that highlight why some of these differences exist. Again, after we've adjusted for age and demography, after we've adjusted for some of the county-specific risks, what is it that explains these differences? And where is there some unexplained variation that might be interesting for further analyses and action from the board? The last parts are all related to looking at time trends. So not only are we interested in comparing the counties and different aggregates of counties across the state, but we also want to look at changes across time. So we'll do that using line plots and tables, as well as then again doing this kind of decomposition activity where we're asking the question, well, can we break out certain pieces that we know have changed, but we expected those changes? They're because of changes in disease prevalence, or they're because of changes in utilization. Those patterns we really want to understand, and again, think about how the changes occurred over time. All of these would be produced and presented with context and explanation so that they can be user-friendly and understood by anyone with different education or experience looking at these different analyses. And the goal would be that it's comprehensive in the sense that it tells a story, and that it expands the state and is looking across key diseases as well. So those are the analytical products. I mentioned at the beginning that there is a fourth analysis that was recommended kind of late in the game. We didn't have a chance to talk to the board about it before. And that is to do some kind of site-specific analyses. We're not able to report for specific providers or payers, or for that matter, providers and payers, but we can look at variation across those. And so one question was, well, how do payments change, and how does site selection really impact that? And that's kind of a hot topic in understanding the impact of site selection. And so an idea is to use the All Payer Claims database to look at variation in the cost and the prices paid for specific services. It would be a subset of services. I want to emphasize that the fourth analysis is something we'd be kind of squeezing in. And so it's not exactly clear how much we'd be able to accomplish, but wanted to recognize that it was recommended to the Analytical Support Initiative and get feedback. Jane, over to you.
Sorry, had to get to the unmute button, which always seems to be elusive when you need to unmute yourself.
Yeah.
So, quick question, and I don't know whether analysis 4 is getting at this, but for example, in the types of care, I think I saw a reference to ambulatory care. And can you, in terms of granularity, are you able to look at differences in site of care, i.e., independent physician office versus hospital outpatient department?
Yeah, so that would be the goal, is that it would be more granular than much of the other analyses. You know, the other analyses are at this kind of level where it's ambulatory care, hospital inpatient. But the goal of this fourth analysis would be to drill in a little bit deeper. And again, we can't call out, you know, by any means payers or providers. We don't intend to do that, but it would be highlighting where the type of facility would be making the biggest difference in prices. So so the goal would be to be getting at some of what you just mentioned.
Other questions for Joe? Bianca?
Joe, could you just give a little bit more specificity when you say service line analysis, what you have in mind? I mean, I see that in one of the other products, there'll be some condition specific analyses by price as it is. So I'm just trying to understand kind of how, what is it that's new here? Or what's the comparative kind of unit? I'm just having a little hard time picturing it.
Yeah, great. Thanks for asking the clarifying question. So the other analyses really focus the unit of analysis on the treatment, the whole treatment of a disease. So an example would be diabetes. What is an outpatient visit or an inpatient admission cost? What is the utilization? So the frequency of those use for that specific disease. But it doesn't go one step more granular and say, we're looking at this specific service within a facility. So it's not looking at MRI, it's looking at the visit as a whole. And the idea of this fourth analysis is to go down to like specific activities within a facility, specific operations, specific procedures. That's kind of the level of granularity we hope to get at. And that's why it would, you know, not be across the 161 diseases like the other analysis, which is really much more comprehensive. It would be at the very beginning identifying those services that we're going to focus on, which would be a very small subset of the services that are fully provided. So it'd be pretty granular. Does that kind of answer your question?
Yeah, maybe now that you have a better understanding of that, then when you say price, then it's price to whom?
Yep. So for the first three pieces, it would be, we're looking at payments, and we're looking specifically at payments broken up by 4 payers: Medicare, Medicaid, private insurance, and out-of-pocket. So again, it's much more aggregated. For this analysis, it would be payments, but it would be payments by the insurance or out-of-pocket. So it would be agnostic to which payer it specifically is.
Okay, thank you.
Kim?
Kim?
Yes, I'm wondering which, if any of the analyses would start to indicate what is being purchased, I guess, by in terms of quality outcomes, actual health.
Mm-hmm.
I know that you mentioned, disease prevalence.
Yeah.
And of course that maps to health status, but in a particular way, right? So measuring disease is one way of making so you can make assumptions about health, but it's not quite truly health. Or so is there are there components of the analyses that would start to show us or give us clues about what we're getting for what we're spending besides procedures?
Yeah, thanks, Kim. Not really, to be frank. So really, all four of these analyses don't focus on outcomes. They really are all about the kind of the actual processes, the utilization, price, and less about outcomes. It really, in some ways, it's trying to abstract from the inputs as well, right? We're standardizing on risks or the impact of disease prevalence and asking, to what degree can we learn about utilization and price without looking at those other pieces. Doesn't mean that's not something we can do. It just means it's something that hasn't been prioritized for this kind of first year of analysis.
Right, understood. Yeah. Okay, I was just thinking, maybe I was missing some, there's sort of a step one, that really is preparing, starting to indicate something that we could detect and identify, here is a path of further analysis that really worth pursuing because there's some kind of indication and in the initial set of analyses. And I didn't see it or feel it, but I wasn't sure. So thank you.
Yeah, no, and I think that's super valuable to keep in mind too for potential second iterations of this work.
Great, thank you, Joe, for these recommendations for this analytic strategy. I'd like to ask the board if there's a motion to adopt the analytic strategy.
So moved.
There's more slides.
Oh, more slides. I'm sorry. Keep going, Joe.
No, that's okay. I think we have just a few more minutes. And actually, these are just more kind of conclusions. We've looked at you read the room right, Sue, that we've done most of the heavy lifting here. So there's a couple slides here that just highlight how we hope these estimates and products could be used. First and foremost, we hope they're useful to you guys, the cost board. The next slide highlights, some potential use cases. So this is a list that's been published elsewhere of common activities for cost boards, and so we've looked at this list and asked where we think some of our research might be able to fit, and we hope that it could be useful for these sort of analyses, these sort of actions for the board. And then finally, the next slide highlights that we also want this work to be beneficial to other state organizations, other key stakeholders, not necessarily public stakeholders, but stakeholders in general that are interested in understanding healthcare and healthcare spending in the state. And if you click to the last slide, there's a list of different organizations, some of which are public agencies, but others which are not, that we think could potentially benefit from some of the analyses that we're doing. The very last slide is simply just a timeline that says where we're at. So the goal is to finalize kind of our plan of attack in December, today, ideally, and then move forward with building the data set and then producing the 3 analyses really in late summer and early fall of 2024, with our report really coming about a year from now, with the hopes that it could be useful for your 2025 legislative report. And the last slide, I keep saying that, is this one, just kind of summarizing the path forward. So again, the goal is to get a concrete path from you guys, 3 real concrete, discrete options. One would be to just approve the 3 analyses. A second discrete option would be to approve the 3 analyses and say, try to do the 4th as you're able. And then, of course, we're open to additional ideas as well. But really the goal being a concrete path forward.
All right, now I get to thank you for these recommendations, Joe. And Bianca, you've got your hand up again.
Yeah, I just have 2 clarifying questions. Just as you kind of went through those slides, is one of the products like a dashboard that's interactive? And when you talked about these other people who are potentially using it, it seems to suggest that there's something other than a report. And just when I hear maps and all the different configurations, I'm trying to figure out what does that actually look like? Is it a dashboard that you're developing?
Yeah. Thanks, Bianca. So that was discussed and not budgeted. And so right now there is not a dashboard. I do think for a lot of what we're talking about, producing a dashboard would be very appropriate. And I had some discussions with a couple experts on this recently, and they were really pushing for that same thing, that what this sounds like is really ripe for a dashboard that could be used by a lot of people and could be updated over time. And so that's great feedback. One of the things we'll do is evaluate our current budget and ask if that's something we can do. But as currently written up, there's not a plan to do a dashboard, although we've received good feedback that it would be recommended.
Maybe between that activity potentially being added on and having this analysis for and a cautionary note you said at the very beginning of this, which is that this is an add-on project and it currently isn't in your timeline. I'm just a little concerned about trying to accomplish all 4 things in a 1-year period. And I'm wondering if we're really trying to fit all these things in to a 1-year period, because I can imagine doing service line comparisons and using APCD is a huge task. That's not a small addition.
Right.
So if you could just comment a little bit on kind of feasibility in the 1-year timeline you currently have.
Yeah, no, thanks for raising that, Bianca. I mean, I think we initially wrote up the 3 analyses and said, this is what we feel comfortable doing in a year. And so I think, admittedly, there's a little bit of trepidation about adding something that's so distinct. What the ASI conversations were is, you know, kind of posing the question internally to ourselves, is that site selection analysis so important that we have to squeeze it in? And since it felt like a pretty important question that we wanted to take to the board to get feedback on. I admittedly think that it would be us beginning that component and maybe having some preliminary analyses, but to do it, like you said, in full is a major project and is quite distinct from the first 3 analyses. The first 3 analyses go well together. The 4th is actually, you know, quite distinct. And so I share some of that concern about timelines. And that's why really the number 2 here is to explore the 4th analysis, but not necessarily commitment to, you know, finalize any estimates on the 4th analysis.
Thank you, Joe, for that clarification. All right, is there a motion to adopt the end?
But I have a question. Sue.
Oh, sorry, Blends right in with your
Blends right in
tiger.
with your lion.
Oh, sorry. Joe, my question is, like, if you're thinking through on a cost benefit analysis, which do you think would actually help the state out more? Doing the site selections, spending impact, or getting the dashboard? If you're going to spend, you know, time and money, or which of those 2 things do you think would actually benefit the most?
The most recent feedback I've got really aligns with the dashboard, that Bianca's comment and concerns about the 4th analysis, and earlier in the week with some conversations with people doing this similar work in other states have led me to feel like the dashboard would be a higher priority, and the 4th analysis, you know, that holding off on that might be the right thing to do.
It sounds like, oh, sorry, could I ask, because Joe has an alternative concrete path forward. So I know if we're moving towards a vote, I guess I'm curious, because we haven't really talked about an alternate concrete path forward. So I just, before we move to a vote, I'm just curious what you meant by that.
Sorry, thanks. I guess that wasn't clear. Was you guys can propose a concrete path forward. If you say, oh, we like the first 2 analyses and the 4th, but and we want to make sure there's time for 4, so don't spend time on the 3rd. That sort of concrete, you know, would give us, you know, we could go into 2024 knowing our plan of attack. if that's the sort of feedback we got. So that's what I was envisioning, is something from the board that plays with these different analyses and prioritizes them in a different way than we've done. Does that make sense?
Yes, thank you.
Other questions? All right, so I again want to thank Joe for this. Is there a motion to adopt the analytic strategy?
I would move that we choose option one, which is the analytic strategy based on the first three analysis.
I'll second that.
There's been motion to adopt and a second for option number one. Is there any further discussion?
Does that include the dashboard?
So the question, Joe, was will that definitively add a dashboard? I heard you to say that you were aspiring to create a dashboard, but hearing that from other states.
What I would feel comfortable committing to is that we will try to do a dashboard with the budget that we have and explore that. I think because it's we have a fixed budget that we're working with, I don't want to commit to the cost board to do something that we can't necessarily do, but I'm optimistic. We, tend to run a pretty lean ship, and I'm hopeful that we could do that, especially because it's feedback that we've gotten from a few groups now. So to answer the question is, number one in my mind, as it sits, does not include a dashboard, but approves a strong recommendation from the board to try to do a dashboard if you're able. And that would be, that's what I would feel very comfortable with.
Jane?
So I clearly understand the concerns about the value of having a dashboard and doing option number one. And whether it's in the context of Joe's work or others, I would hope that we wouldn't lose sight of the importance to look at site of care. And I'm thinking of it not only with respect to hospital outpatient versus independent physician, but also hospital versus ambulatory surgery center. And then, we pretty much understand that specialty drugs don't show up, physician administered drugs don't show up in retail pharmacy analyses. Yet what we're seeing is over half of spending is on specialty drugs, even though it's only under 10% of the scripts actually written. So trying to have an understanding of where those drugs are purchased and where they're administered just seems really important if we're trying to get at what's happening with cost trends and what cost drivers are. So if not Joe's work, I would hope that at some point we'd have the capacity to take a look at that.
Jane, so noted. And I would also suggest that incremental step of option two, being aspirational and getting to later on, possibly, maybe under a different arrangement, would also tease out too workforce type, because, we're hearing more and more about some very innovative, concerning trends like remote hospitalists at night shifts, and just, so I think it would tease out on site selections, answer some of these other questions as we keep digging in. So we need to hold that for the future. And I think, Bianca, you have your hand up. Did you want to comment on Jane's comment?
Yeah, because I certainly think I agree. The analysis would be useful and helpful, and maybe it goes to, I think it was Eileen who asked it earlier. Kind of this, there was this question kind of embedded somewhere earlier about prioritization and what might be more helpful sooner. So and I think that's where I get to the alternative concrete path that we really haven't had discussed as a board. Really, is that do we, in kind of in light of Jane's comment, do we think number four may be more of a priority than one of the three other activities or even two of the other activities? Because this is a fairly significant, at least from my perspective, the APCD analysis is a significantly different analysis than what the other pieces are, but it could be important. And maybe we as a board would prefer that one over one of the other options, but we really don't have an option currently on the table. I'm having a hard time looking at the other three activities to say which one of those three would I deprioritize over this one. I just am more concerned about the logistics of trying to cram too much information all at once and squeezing it in to a time frame and a budget that may leave us with kind of a little bit of everything versus more deeper, careful analysis of a few.
Thank you for that point, Bianca. I remind the board, though, that we have other kind of structural things in play. So this work from the ASI is additional. This isn't the only basis for our work. So there's a lot of other data reports that we'll be looking at throughout the year. And the partnership with IHME and the ASI is really for them to kind of, again, overlay their epidemiological perspective. So I am comfortable with option one. That is the motion that's on the table. I would just ask, are there any other questions to discuss this, or can we move forward with taking a vote? People comfortable moving forward with Eileen's proposed motion of option number one, given the discussion we've just had? I heard Jane kind of say a friendly, let's aspire to get to kind of number two in the future, but kind of be patient about, let's see what we got as we get the first option underway. All right, so there was a motion, there was a second. All those in favor say aye.
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 Are there any opposed? All right, the motion is approved. Thank you, Joe, for your work. And this is going to be fun as we go along to keep layering in and seeing what more we can produce.
Thank you.
It'll be an ongoing journey on data and analytics. All right, next I'd like to welcome Vishal. He's our Chief Data Officer at the Healthcare Authority, and he's going to provide us with the overview of the preliminary results of the benchmark. And this is under tab 5. And Vishal, over to you for the long-awaited benchmark data, baseline data.
Thank you, Chair Birch. Thank you to the board members for having me back. You remember last month I presented the board about the path that we've been on and what to expect. Just reminding, these are preliminary results. There's a lot of work that is still going on and we still need to do. I'm just going to launch into it so we have time for discussion at the end. A quick overview, we're just going to go through the spending growth, what it looks like in the state. Just a little bit there, you'll see the term other spending there. That really includes the spending associated with labor and industries, Department of Corrections, and the VA. Not really neatly categorized into most other, like Medicare, commercial, Medicaid. So it's kind of set aside, and you'll find that in the appendix at the end of the presentation. Next slide, please. So this is just a reminder of the path that we've been on. The board established the benchmark and the subsequent 5 years. The benchmark really represents a common goal, starts to create a common understanding of our goalposts, and really is a starting point. We start the conversations about what does that mean? How do we perform against it? And then what do we do about it? Next slide, please. And you've seen this slide before. These are the benchmark targets that the board has determined for 22 through 26. Just reminding that the benchmark is based on a hybrid of the median wage and PGSP. So there is an objective mechanism and methodology to develop the benchmark. Should the board choose to reevaluate that decision, we have the ability to go back and do so. Next slide, please. In terms of the work of creating the reports, calculating performance against the benchmark, we are in the current reporting cycle. I am going to acknowledge the HCA analytic and policy team. We have anticipated since the beginning that it would take 3 to 4 months to analyze the data once we have all the data completed. The team had about 3.5 weeks to put this together. So we're calling it preliminary, and I think by any standards, this is a very decent and wholesome product given the time that we had available. But all that to say, there is still work going on to dig deeper. So as you have questions, please share them with us. It will help guide our analysis and as we dig deeper into it. Next slide, please. This is just, you've seen this before. It's just an explanation of the terms, the difference between total medical expense, the net cost of private health insurance, and the total healthcare expenditure. On the next slide, you'll see that we measure the state performance at the total healthcare expenditure level. We measure the market performance at the total medical expenditure level. And then for the future reporting, which will go into the provider payer level detail, we will be focusing on the total medical expenditure. And the difference really is the net cost of private health insurance between those two terms. And as you're seeing on the slide, these are the data submitters that we have. I just, again, acknowledge out of these 14 submitters, the team processed over 25 submissions because of submissions and resubmissions and resubmissions. And the next cycle is going to be better because we've learned from the first cycle. The next couple slides are definitions. I'm not going to go through them. You have them in your board packets. As you're looking at the terms on the different slides that have data and graphics, these are the definitions that I used to articulate what we're trying to convey. The next slide on caveats and limitations, I'm not going to read through all of it, but just for the board's awareness, there are two types of limitations we have. One is by design. So the board decided to not include limited benefits as part of the health expenditure analysis. And then there are some that were not by design, but by experience. And that would be examples like Anthem did not provide 2017 data. They had very high level of difficulty producing that data. And Humana has not provided Medicare Advantage data, which we have learned is similar for other states as well. Other states are also experiencing the same challenge getting MA data from Humana. So just some things to know for us. All figures are also net of drug rebates, but the rebates have all been applied to the retail side of it because it's just too complex to tease out the medical application of the rebates from the data that we've collected. So from a total medical expenditure, it does present a complete picture, but as you start digging into the service categories, we could split here about where that particular rebate might go. And I don't know if, I don't know if there's a bang for the buck in splitting that level of here. And again, like Joe said, please interrupt me. I'm going to try and go fast to leave time for discussion at the end. But if you have a question, please feel free to interrupt me. The highlights of the analysis for the state in 2019, the total healthcare expenditure was $48 billion. And you'll see that the outpatient services are significant and growing, which, to be honest, is by design. There is a lot of pressure that's been put on the market over the last decade to move services from the inpatient setting to the outpatient setting. So when we see this, it's not an anomaly. It is by design. The growth between 2017 to 2019 for the 3-year period was 7% and 5.8%. It is higher than, of course, the benchmark that the state has set for 2022, but it's not surprising given what we know about how the market has performed. Medicare, even though the actual per member per year spend is higher than commercial and Medicaid, the growth rate is slower, and Medicaid seems to be growing faster than the other markets, but it has the lowest per member per year expenditure. So those are the highlights, and now we can get into some of the details. For the state level expenditure, you'll see that the total spend went from 42 billion to 48 billion from 17 to 19. Nothing unexpected here, but you'll see the 7.4 to 9.1 growth in Medicaid. And we'll see that in the Medicaid specific data set when we get to it. On the next slide, and per member per year, that's where we see the growth as a percentage. For comparison, Massachusetts and Rhode Island identified a 3 to 4% annual growth rate over this period. But those states have had their cost, I wouldn't say cost control, but cost mitigation strategies in place for a while now, and we're just starting. On the next slide, these are the service categories that we'll see in later charts as well. Something to note here is the top bar on this, which is the non-claims spending. I'll talk about that a little more in one of the charts down the line. But you'll see that the hospital inpatient slice of the pie has gone down by a couple of points, and the non-claims has gone up by a couple of points of the total. In one way, it could be a reflection of a move towards value-based care, because capitation arrangements would fall under non-claims. There's a lot more detail to it. I'm just trying to illustrate just one point. The next two slides are bubble charts representing the service categories and the contribution of those service categories to the growth. This one is for 2017 to 2018, and the next one is from 2018 to 2019. I'm not going to dwell on these charts here. There's a summary chart that compares state, Medicare, Medicaid, and commercial towards the end. We'll spend maybe a couple of minutes on that as opposed to spending time on these individually. On the Medicaid deck, you'll see that the total spending for Medicaid has gone up by 11.5% and 9.8% year over year from 17 to 18 to 19. And the PMPY spending went up 13.8% and 11.9%. And that's where there is, I think, some reflection of state policy in this, but also a recognition that the number that you see, the PMPY number, is circa 4 to 4,500. And when we get to the next Medicare and commercial, you'll see how small this number is when compared to the other parts of the market.
So Vishal, if I could just provide a little more context. During these years, there was some significant directives from the legislature about increased provider rates. There were also emerging needs. We were responding to healthcare market changes and expanding eligibility, and quite frankly, putting up a more robust Medicaid benefit. So it really plays into what you're seeing here, but we can go back and every year we do have to provide to the legislature what's happening with this trend. And our CFO, Megan Atkinson, I'm not sure if Megan's on right at this moment, but has every year had to really account for every bit of this trend movement. And I actually, Megan, your hand is raised. So I just want to see if there's anything additionally you want to comment about behavioral health integration or any of my comments. Go ahead, Megan. Can't hear you.
Well, she needs to be promoted to as panelist, and I just got locked out of the system. So can somebody else promote her to panelist?
Hang on, we're having a little technological glitch.
She should be promoted now.
Go ahead, Megan.
Thank you, Chair Birch. And yes, I just had to get moved around, so I changed my camera. So yes, I think I would just echo a lot of what Vishal and Sue have been saying about what we see underlying the Medicaid trend that you see here, and then I believe there's a couple more charts. During this time frame, 2017 to 18 to 19, the state was in the midst of its behavioral health integration. So there's a couple of things that you have to take into consideration here in terms of how the state has set up the Medicaid program and in terms of which agency is paying for the services during this time frame. And then in addition, which entities are reporting in this data collection. I think we can expect the data on Medicaid spending for these years up to 2020 to be a little bit chaotic, for lack of a better term, because of how we were integrating the behavioral health regions over into the managed care contracts. Those happened in phases, and it wasn't until we got to 2020 that we had full integration. Now, of course, once we get to 2020, then we hit the pandemic. And so then 2020 and 2021 will look very, different as well. And so I think those are some of the things that we have to take into consideration as we look at these years. So.
Thanks, Megan. Margaret, go ahead.
Thank you. We've heard testimony from the Medical Association over several meetings about low Medicaid reimbursement. And today we heard about low Medicaid reimbursement for specialists. And we've also heard that there hasn't been an increase in Medicaid reimbursement in quite some time. And I would like to have more information on where we stand compared to other states. It sounds like there are a lot of things going on with behavioral health and so on, but what I'm concerned about is whether access for Medicaid patients is being hurt because of low reimbursement. And also, if the reimbursement is too low, then the providers need to try to get their revenue from other payers. And so that puts pressure on the commercial side. And I would really like to know more about this at a future meeting, please.
So if you don't, Chair Birch, may I make at least an initial response to that?
Yeah.
So I think what I'd like to say is I agree that this is worthy, your concerns are worthy of a sort of broader and more in-depth conversation. Again, I think that's something where with the analysis catching up to sort of where we are in a post-pandemic and post pretty significant legislative investments, the numbers for 2024, for example, for the 2024 Medicaid program are going to be vastly different from the numbers from, the 2017, 2018, 2019 Medicaid program. So for example, just a few examples of things that have been invested in by the legislature. We have a directed payment for a provider access payment, bringing certain providers up to a particular commercial benchmark. We have increased fee schedules for physician services, for trauma care. There have been rate increases focused at various pediatric and adult primary care services. Again, bringing those reimbursement levels up to certain percentages of Medicare as a benchmark. And then most recently, the legislature has approved a new iteration of our hospital access payment, which brings Medicaid hospital reimbursements up to a particular level of a commercial benchmark. I think, and while I say all that, I will say, I understand the dynamic you're referencing, where if Medicaid is sort of under a particular cost benchmark or cost line, and then commercial is well above that, sort of the idea we've always had is that there's some offsetting, right? I mean, that was part of the theory behind the ACA eligibility expansion, that by bringing people in from the uninsured side onto Medicaid, that you would address some of that uncompensated care. I think one of the things we're looking at the Healthcare Authority, because how our purchasing extends across Medicaid, the commercial market, and into our Medicare plans as well, is sort of how our purchasing in total makes up the total in terms of either a particular service category, a particular amount, the total payments for particular large providers, or even within regions of the state. And then knowing how we pay compared to, let's say, a cost benchmark like Medicare, then how is the totality of the state's purchasing, which represents a considerable portion of the health of the state's population, in reference to those benchmarks. So that's just a little bit of I agree with you. These numbers don't reflect a significant number of investments the legislature has been making. And I think we could probably spend an all-day work session just on how the state's purchasing benchmarks to cost. So thank you.
Thanks, Megan. More to come on this topic. Vishal, back to you.
Thank you. I think we've talked about all there is on these charts. I would just, actually on the previous chart, just look at that. The biggest bubble on this chart is non-claims. We'll come back to it towards the end of the presentation. For Medicare, the total spending grew at about 6 and 7% clip over those 2 years, and the PMPY grew at about 3% year over year. Next slide, please. So that's where you saw the summary highlight where Medicare spending growth seems to be pretty low, but when you look at the total number on the left scale, it's a pretty high spend overall. Again, spending by category. Next slide, you'll see that the hospital inpatient has gone from 26% of the pie to 23%, and there has been a significant increase, if you will, in some of the other parts to make up for that, especially the claims other, which in the Medicare, well, it's the biggest pie for Medicare, and that's DME and other services that are not neatly fitting in one of the other buckets. Next slide, please. You'll see the hospital inpatient in the negative category for Medicare, both on this slide as well as the next slide. And we've seen the same thing in Rhode Island, where hospital inpatient actually had percent growth decrease. But then you'll see the outpatient has grown and non-claims has grown and claims other has grown. So it's more of a shifting than anything else. And our speculation is that that has an impact on the growth rate overall of the spend. Going on to commercial, we saw a 5% per annum increase overall for the spending, translated to about a 4.5% and 4% per year increase. For the next slide, please. Thank you. And in terms of the service categories, you'll again note a similar trend, except for, Marty, next slide, thank you. The hospital outpatient on the commercial side has basically made up for any decreases in the hospital inpatient side. And the other categories have pretty much remained static. So there's some nuances between the different markets, but largely the shifting from inpatient to the outpatient settings is pretty evident, at least from the data that we've seen, the aggregate data. The next two are just bubble charts, like we've seen before. You see the outpatient as the largest bubble in terms of growth. And getting to the summary. So this summary chart, we just put all of those together, all of the PMPYs together to just illustrate the point that I was making earlier. Yes, there's growth rate, but there's also the actual absolute value. And when you see that, Medicare outpaces the rest of the market in terms of the actual spend, if you will, even though their growth rate is less. And Medicaid, even though the growth rate is higher, it is actually the smallest pie, smallest piece of the pie. In the next slide, this is where the comparison is, and you'll see that dark blue bubble for non-claim spending. So both Medicaid and Medicare had a good amount of non-claims spending growth. Medicaid had the largest, and so you'll see the statewide impact on that. Non-claims is where capitation and value-based purchasing is the best represented. And what I'm wanting to show here is that you can barely see that bubble on the commercial side. it's an observation. We can say a lot of things about it if we want to. I'm not going to. I'm gonna leave it there. In terms of next steps, where we are, this higher level report really just sets the stage for next year's work for us from an analytic perspective, supporting the board's work. The next data submission call, we're working on the project plan to get that in place, documenting our learnings, debriefing, figuring out how to make that process smoother and better and faster. So we have a better turnaround time for the board. And we are going to start getting into deeper dives, analyzing, how are these, what you've seen in this report is really what is. We haven't really started delving into, well, so what does this really mean? So that's the next part for us from an analytics standpoint. And that will hopefully lead to discussions at the board that could inform, proposals and recommendations of strategies to the legislature. I'm gonna pause here, take a sip of my tea, and happy to take questions.
Are there questions for Vishal? Jane, go ahead, and then Bianca, you're next.
Thanks, Vishal. I know this was a massive amount of work. Just a quick question. Where do, for example, DISH and CPE dollars show up? Is it in non-claims? How does it come in?
They would be showing up in non-claims, yes.
Okay, thanks.
And Jane, I want to make certain I'm clear. You're referring to supplemental payments? Governmental
Yes.
supplemental payments, thank you.
Yep. Sorry, I should have been clearer about that.
No, just want to clarify for everybody. Bianca, you're next, and then Eileen.
Oh, I think Eileen actually had her hand up before me, but somebody else. Okay, thanks, Eileen. I was just wondering if there's any way to get more detail on what's in that non-claims bucket. I suspect that primary care is a big part of kind of how some of that money is being spent. It's just so hard to know. So I'm just wondering if there's any way to get more detail eventually in the future. And great work otherwise, lots of great detail.
Thank you, Bianca. Short answer is yes. That is the work in front of us to dig into, like I mentioned, the capitation payments, supplemental payments. They're all part of that non-claims bucket. We are going to start teasing into that a little bit more. Yes.
Eileen?
So I'm on the non-claims also. Did you say that DME also goes into non-claims?
No, DME was in claims other.
Claims other, okay. Okay, I just wanted to make sure where things were going, thanks.
Yes, and the definitions are included as part of the slide deck. But yes, happy to answer.
Other questions for Vishal?
So the next slide, please. And we had some discussion questions for the board, just to ponder if there is time, Mandy, that might give us direction as to like what we as analysts see things, and we have questions and we want to dive into them. Some of those questions are similar to what you are asking, but the board has a much broader and deeper perspective on the state of affairs of healthcare in the state. So we'd love to get direction from you as to what should we be doing? What should we be digging into more or following up on? And it's okay if there, I don't want to put people on the spot. If there's future discussion and feedback, happy to take that as well. Or
Bianca and then Edwin.
Yeah, thank you. I mean, there's so many things, I guess one can keep going down certain pathways, and I believe we're not doing risk adjusting, I think, in our own benchmarking, but it is worth certainly making sure that we don't overemphasize how high Medicare spending is when you consider the fact that it is a much older population with significantly more chronic conditions. So I think that context setting is certainly going to be important moving forward, just in terms of understanding the level. And so maybe that's an area of analysis, is to figure out how to incorporate the age components or creating some kind of comparison based on some age bands, and maybe for certain disease parts. But I realize that that's the part where Joe was talking about earlier, some of the work that he'll be doing.
Thank you, Bianca. With age and gender risk adjustment has been factored in, but not for the baseline. Yes, as the driver's information is being analyzed, those factors will be applied to better understand what is truly a driver versus just a factor of the circumstances of the population. Yes.
Edwin?
Thank you. And yeah, let me just second the excellent work here and really appreciate the really intuitive kind of data visuals here. I wanted to kind of drill down on the primary care number, because I think we've talked a lot about primary care on prior board meetings and how this is a potential area of emphasis for us. Just kind of a technical question first. I'm trying to, in these service category contributions to growth plots, I noticed that primary care number is not available for the Medicare, or at least it's not presented. I was wondering, was that just not possible, or was that just omitted?
It is a limitation, Edwin.
Okay, and
the limitation is with the data submission, the primary care attribution is calculated based on the data provided by carriers. And for fee-for-service, the carriers have to attribute their lives to providers and let us know which lives belong to which providers for us to attribute the costs accordingly. And Medicare fee-for-service, we just didn't get that.
Okay, that makes sense. I know Dr. Zerza has presented some prior work about defining primary care. I was curious if there's any potential avenues that we might be able to use either with the Medicare data or in other data areas?
Yes, if I were typing, I would put 3 exclamation marks with the yes.
Yeah.
This
awesome.
work is absolutely in hand with the primary care spending analysis work that the team is actually the same. That's working on both sides of it. Yes.
Excellent.
Dr. Zerzantal's going to be presenting here in just a minute, so we'll get an update more on this primary care, but great questions.
Fantastic. And just one more question. I wanted to, maybe a question / comment. In looking at the two numbers that we do have for commercial, I noticed that growth number is quite a bit lower than for Medicaid, and I thought that was really interesting. And I don't know if there's any context in terms of what might be driving that number. And I think it's
Edwin, which slide are you looking at?
We'll get
23.
Okay, just wanted to share with everybody so that they
Right, so Edwin, the growth percentage numbers that we would mostly expect would be somewhere between 2 and 5% per annum for markets. The Medicaid number is not as much reflective of the market itself. It's more reflective of the state policy, and as that has over time. So that's probably the simplest way to explain it. There's a lot more detail underneath it, and I'm sure Megan will be able to provide a lot more behind that.
I think that's a good enough answer, at least for now. I think that explains at least the number that the difference that I'm seeing in the commercial versus Medicaid. Thank you.
Any other questions for Mr. Shaw? All right, well, Vishal, this is really exciting that we finally have this information, and it's going to really be great as we keep digging in and discussing. And the board, I know, is stunned right now because they're just taking it in. But we are going to keep utilizing this information as we keep moving forward with examining healthcare costs and strategizing for our possible solutions. So to you and your team, and I know the industry partners that did comply, really, this was a tremendous amount of work. And I remind the board and the public that this is just our first year. Every other state, the other 8 ahead of us Department of 7 have said the first year is always the hardest. We'll get better at it. It'll get more refined, but huge accolades to you and your team for getting us this far. I want to move us on now to our next topic. Dr. Judy Zerzental is going to review the Primary Care Committee's previously approved definitions, and she's going to provide an update on utilizing the definitions. So this is under your tab 6. And Judy, over to you.
Great. Hello, everybody. And yes, there were some great questions and discussion in that last bit. My section will be short because you have previously voted on the narrow and broad definitions, and I wanted to provide some updates on where the Primary Care Spend Committee is. So we have further refined the definition for our claims-based and non-claims-based methodologies, and I'm bringing that to you today. The 2 second parts are still in progress. We're going to start that work in the new year, and I think we'll have some interesting ideas to come back for discussion. So next slide. So you have previously approved and voted on a narrow and broad definition, and that includes narrow and broad differences in terms of provider types. These provider types that you see on the screen are the ones that are included in the broad definition. So everyone else is in the narrow, but just to give you a sense of who's there. And then on the next slide, we may want to come back to this if you have questions. The Primary Care Spend Committee has decided to just focus on the narrow definition. So we are not going to measure the broad definition, just the narrow. And these are some of the key considerations of why we decided that. So first, the narrow definition is more closely aligned with other states. So we'll be able to benchmark and compare ourselves a bit. This includes the states that were used to get to the 12% goal. And so I think that it's important to sort of match those in figuring out where we are and how we get there. The second reason is that the narrow definition will require greater primary care investment to hit the 12% target. As you saw in the graphs, we have increased sort of on all fronts this non-claims-based care, and we really want to make sure that we have the right amount of investment in primary care. And then finally, the broad definition, you could argue is more direct in supporting team-based care, but the narrow definition still supports that team-based care due to the increased investment in primary care more broadly and figuring out how to make primary care stronger. So that is what we've been up to. Are there any questions about this change?
Bianca?
I just have a quick clarifying question about the bariatric medicine, family medicine, and internal medicine docs, but particularly the family medicine, bariatric medicine docs, and why they are not included in primary care.
So when we had the broad definition, these were the folks that were added into that broad definition.
Yeah.
But when you look at other states, these types of providers are generally not included. And in bariatric medicine, some of those work in a weight-based specialty clinic. And so the committee decided that these were probably, that there could be some primary care that is happening there, but that to get sort of the, I guess, the most bang for our buck, that we really wanted to focus on what we knew was primary care and how to support that best. We still have in the definition the code set and the where, the location of these services. And I think those sort of 3 pieces really focus and hone in on where the bulk of primary care is happening.
Okay, thank you.
questions? And Judy, maybe you might want to comment a little, since so many of our rural frontier areas are covered by the APP providers. What's the thinking about over time as other states have to capture more of the broad definition? Are there thoughts about how over time we'll do a wider catch as we get kind of the initial primary care look, or what are you thinking about the future?
Yeah, so both advanced practice nurses and physician assistants are in the narrow definition. So they'll be captured, and they certainly provide important care both in rural areas but also in urban areas. The two that were in this broad list that we are not going to measure as primary care are midwives and the advanced practice registered nurses that are only psychiatric providers. So those ones won't be in the primary care definition. They may be in primary care practices, and they may be providing some primary care, but the bulk of what they do is probably not primary care. And so that was why we decided to focus on the narrow. Yeah.
Thank you for that clarification. Other questions? I keep looking at Eileen's lion because I can't tell. We're gonna have to get us a zebra or something next time, Eileen. All right. We're not seeing any other hands up. Judy, thank you very much. I know you'll be coming back with future updates on this work. So we appreciate you being here.
Thanks.
All right. I'd like to move us on now to our next agenda item. This is under tab 7, and this is regarding the nomination committee. So we think that, and in your board packets, there is some good discussion that we need to have about nominations. The committee is going to assist the board in recruiting and evaluating member nominations for its subcommittees to ensure an effective and appropriate mix of representation, subject matter, expertise, and diversity that's going to allow the committees the ability to properly fulfill their roles and adhere to the strategic vision of the board and the board's mandate. So the nomination committee would be set up to recruit and select the most qualified candidates to help enable the board and its committees to fill vacancies in a timely manner and to continue focusing on the important work they're doing. And under tab 7, there's also a draft document describing the nominations committee, and you'll see it there on the screen as well. I want to mention that we've been notified that 3 members are stepping down from the advisory committees, and we've received or will be receiving new nomination requests for the members leaving. And those materials as well are in your packet. So this is a real opportune time for us to establish a nomination committee to fully evaluate the mix of representation on the advisory committees and assess what background and expertise may be needed to round out our advisory committees. So I would love to hear your thoughts and just open up general discussion for this concept. Eileen, we see your manual hand and we barely see your lion hand. Go ahead.
So I just had a question. The board or this nominating committee for filling vacancies of the board itself, that would those recommendations would go to the governor, right? Because it's still the governor that appoints for the board.
No,
Not for the committees.
Not for the committees, but for the board itself. That's
Yes,
what I was-
exactly. For any board members, if the nominating committee made any.
But doesn't, the way I read this was that the nominating committee would actually also help work on basically vetting people for the board. Is that, was wrong?
Encouraging applicants to apply.
Yeah.
we would, the nominating committee could still serve to, get names over to the governor's office for any of the board level nominations that he or she would make. But for the advisory committees, it's really been kind of more in my
Right.
purview or staff purview, and we think it's time to open that up to a committee process.
No, I agree. I just wanted to make sure I understood where the nominations were going.
Yep, and I remind you that we have 3 committees now, and is our ASI committee? No, it's not really a committee. Okay, so we have 3 formal committees, and with the number of members on those committees, people moving and changing jobs, this committee is going to have some work to do just to keep kind of creating a pool and of potential nominees and also screening. Other comments, or how do other people feel about the establishment of this nomination committee? Bianca?
I generally like the idea of this committee, so I agree with the concept. I think to Eileen's point, and maybe just a clarification to kind of close some loops on the document, is making clear kind of who is the decider at the end. So, and I say this as someone who's recently served on a search committee, for example, where there was another group that ultimately overrode some decisions. So I would just make it clear who is the actual chooser somewhere in the document. So we're nominating to some
board.
group. Yeah, well.
Yeah, we can update this document.
Yeah.
This is just a draft, so you could see this.
Yeah.
We could certainly bring this back to the board for their additional feedback and comments. This was just something to get the conversation going. We can definitely edit this draft outside of this particular voting process.
Overall, I like the idea, however, and its intent.
Sue, I just want to concur. This is a lot of work to do, to track on the nominating, especially as people change and move. And this is something we've similarly addressed at the exchange, and it makes sense.
Other comments or thoughts? So far, I'm hearing maybe we need to refine the document just a little bit, so it's a little clearer, but that people are generally supporting. Good, because I don't. All right, and I'm also curious, who might be interested in volunteering for this committee? And if so, if you could make sure to either notify me or Mandy about your interest. And we are also faced with some immediate needs. So, well, first off, let's go ahead and just say, is there a motion to create a nomination committee?
So moved.
Thank you, Jane. Is there a second?
Okay.
Any more discussion? All those in favor, say aye.
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 Any opposed? Right, the motion passes to establish nomination committees. And like I said, please email Mandy if you're interested. If not, I'll recruit you to help me, because Andy and I were taking.
Can it be a delegate of a board member?
I think that might present a problem because of the authority that the board has to place.
Okay.
The members.
But I assure you, staff have been great about assisting with this, so I do think they will be very efficient meetings. And
I suspect you'll
Ingrid is trying to say she's interested in helping.
Try to say Leah's.
I'm not sure because of the authority that it's possible to have a non-board member.
Yeah.
But certainly something I can check with our AG.
And yeah, I think let's clarify that and we'll bring that back. But for the time being, I would just ask for board volunteers just so we can keep going. Because as I said, we have 3 positions, and we have at least one request for nomination. And is there a nomination to send current nomination requests to the nomination committee? You want to?
Motion.
Is there a motion to begin to work on these 3 to whoever's going to volunteer to be on the nomination committee? Or do you want me to continue in the absence of the committee being established just yet? Do you want me to make these appointments?
It would be for the board vote. So either the board could vote on the pending nominations, although there's still 2 in the wings. We have received 3 resignations. There's only 1 current nomination with an application. The board could vote on those or send those to the nomination committee, and there's an alternative vote there, which would permit a temporary appointment, so that the nomination committee could be established. So we could send them not to the nomination committee to be established with the permission of a temporary appointment, rather than the board examining it this time. Does that make sense?
Eileen, go ahead.
So I just need to clarify because it didn't quite make sense. Eric Lewis is the only one that's actually up for nominate to be appointed at this point, right? And then the Kaiser and who was the other one? I can't remember. Is it medical? That are leaving. We haven't gotten any nominations from the organizations yet. Am I correct?
That's correct.
So it seems like what we should be doing this month is going ahead and approving Eric and sending the rest to the nominating committee. Mike?
Is that a motion?
Yeah, that's my motion.
Eileen has a motion that the board take action on the current proposed candidate, who is Eric Lewis. And is there a second to that motion?
Second.
Okay, so Margaret Stanley, I think, was the second. Is there any further discussion on that? Seeing none, all those in favor, say aye.
Aye.
Any opposed? Okay, that passes and we'll notify Eric. Now, on the other 2, I think we are suggesting that those 2 open positions go to a newly forming nomination committee. Correct?
Correct.
So is there a motion for that next action?
So moved.
Thank you,
In the last
Jane.
one. But so moved.
There aren't temporary appointments for that position, so I don't know that we need to vote on the last one because we are still waiting for documentation.
So the nomination committee, again, will get formed. Please let us know if you would like to volunteer. If not, we're gonna voluntold you. And we will continue to review nominations as they come in. And we will notify Eric that he has been appointed. Okay? All right, thank you, board members. Mandy, do you want to provide us an overview of the 2024 year calendar for the cost board?
Yes, I would be happy to. I will wait for the slide to sort of get there. Here we go. So the work of the year for the cost board is really scheduled around the work that it has to do. And so focusing on a legislative report that's due early on, different from some other legislative reports, is actually due in August. So in order to complete the timeline, we usually wrap it up in June for our final vote in June, so that it has that ability to process through the governor's office and do that back end work that it usually has to do before actually being filed. So our June date is really the first focus of the board. And so there's a series of meetings. You'll find that there's a series of meetings in before June, from April, May, and June. And that's really to focus in on getting those last recommendations that the board would have into the legislative report, getting a draft before the board in May, and then finalizing that report in June. So there will be some back-to-back meetings in that first part of the year. And I want to circle back to February, because in February we have an in-person retreat scheduled. So please hold your calendars for that date. We'll be getting invitations shortly out to members, but it will be a longer meeting, and we look forward to getting the board members together to really spend some time on strategic planning and also enabling board members to get to know each other and the work. And then later in the year, there'll be a September board meeting, and then there'll be 2 back-to-back meetings at the end of the year. And that's really to encapsulate the ASI project and make sure that there's sufficient time to talk about that work, as well as hopefully there'll be another benchmark update with more information about the benchmark.
Great, lots of information that we'll be digesting and discussing and getting public input on. And then we have really important work about our recommendations and decisions that have to be made.
I see that there's a hand raised.
Margaret, go ahead.
Could we turn to the proposed meeting dates, please? For 2024, unfortunately, I have a conflict on the February 9 retreat, which I'd really like to be able to attend. So I'm wondering if you could consider some alternative dates in February.
That unfortunately is really difficult because of the number of public meetings currently run by this unit, and getting to that February 9th date was actually very difficult, especially given session, where, you know, a lot of folks actually have session commitments.
Well, you know, we have never met in person, and I think it would be very beneficial for us all to get together in person, but it would have been good for us to be asked about whether these dates work for us, because I'm really sorry to miss it.
I'm sorry as well. I'm not sure what we can do, because my guess is that if I move the date, that some other member might have a conflict too. We can take a look at it.
Margaret, are you gonna be, I know it's always best to be in person, but I'm just wondering about your ability to participate virtually just for listening in, and or are you gonna be out of the country, or?
I think that's the day I'm traveling by airplane, so to the East Coast.
You can't see this, but the staff have created a matrix of public meetings that they juggle and toggle, and it is really becoming pretty extraordinary with the number of advisory committees and other activities that they've got with the Universal Commission and all the other intersecting parts. Let us look at this, but it's likely, Margaret, we're gonna have trouble moving it because it will toggle 8 other commissions and committees. Eileen, your hand is up.
Yeah, I mean, I agree with Margaret. I think it would be really beneficial to get all of us together. Yeah, in the same room, just because that has not happened with this group yet. And the other question that I had was on the hold for potential, so are we gonna have a date for on those, because I would suggest like putting some dates on the ones that are for holds, just so we do hold.
There are dates actually held for those. It's
really?
just, yeah. For the advisory committees, the dates are actually held.
Oh, but
and
those are all for
those
advice?
committees, they're advisory committees.
But I thought that because the stuff that's coming from IHME is coming in August, September, and October, that we, like August and October, we might need dates for ourselves to be able to review the data as it's presented.
The data comes out in November. So that's the soonest that the IHME project will be available.
I thought
And there will be a March report as well. So that's scheduled as well.
But I thought on his thing, he has that they're doing each like 1, 2, and 3 that they were doing in August, September, or October. If you look at his presentation, maybe we need to get that clarified.
We will, let us take this under advisement, and we'll refine things with IHME for potential dates to put holds. It's easier for us to hold and then cancel.
That's what.
And that is why the staff have their hold for potential date. We just couldn't confirm yet with kind of the workload and whatnot. Yeah, it's not on this list, but it's not, but so they're asking for those hold months to actually have a date, even though it may be canceled.
And can I just clarify the slide that's up right now on the screen? These are our dates, because currently there are no calendar holds. So
yes, we're
as far
still
as I know,
have that
yeah,
underway.
okay.
These
Okay.
are the dates currently for the cost board. Yes.
So these are the proposed dates. So with staff, we will take this back and kind of look at it, see if there's any way. I don't know if it's possible for us to switch to April, or January is too soon. Let us go back and noodle on it, and we will bring it back, but hold these dates currently on your calendar. And then we will make recommendations about the holds on this calendar for potential dates, because I hear you, Eileen, saying it's easier to lock in and then cancel if we don't meet them. Margaret, I think your hand is up again.
Yeah, Sue, I could do a day or two earlier on that retreat.
Yeah, Margaret, it's just that if you look, you don't have this other massive document where they have to move 8 other committee meetings to move dates around. So that's, I think, what we're saying. Let's go back and see if there's any way we can juggle a day forward or backwards, or well, not backwards.
Okay.
Margaret, are you available on the 7th and 8th?
So actually, I worry that this would just involve a conversation and then somebody else
Right.
might have a conflict. So can anybody just send me dates that they're not available in February, I think is the good approach to this.
Okay.
And we'll begin there.
I'm gonna try to accommodate Margaret. It's just we can't answer it today because of this Rubik's Cube of meetings for other staff and all the other related meetings. All right, I want to thank everyone for attending today. I remind you and the public that the recording and the summary of this meeting will be posted shortly on our website. I want to thank the presenters today, especially Liz Shaw and his team. Joe, you and your team. Our next meeting will be sometime in February. We think February 9th, but please hold that day on your calendar before we get back to you. Just hold that for the time being. And you'll be receiving calendar invites for the rest of the year very soon. And I hope you have wonderful holidays and you can really splurge and lean into those great celebrations that you have. I look forward to seeing you at the next meeting. This meeting is adjourned.
Bye all.
Thanks, everybody.
Thank you.